All right, Dr. G, thank you so much for being with us here today. And I wanted to just start off quickly and have you introduce yourself and explain your background and experience with treating mental and emotional conditions.
Sure, Caitlin, it's great to be with you and DHA Labs. And I've been a practicing psychiatrist for over 30 years. I came into psychiatry really through the back door of orthomolecular medicine. So I was going to orthomolecular psychiatry meetings before I was a psychiatrist. So I've had this long interest in nutrition and brain function and kind of got consumed by the traditional psychiatric medication model during training. And 30 years ago, when I got out in practice, kind of found my roots, which is how nutrition affects brain function.
hmm Yeah, and it does significantly, right? And so I'm sure you've been studying that and practicing for a long time. Is there a reason why you started this work and why it's meaningful for you?
Well, part of it was just an interest, from early adolescence and college. But what happens quickly when you're in the field of psychiatry, the field of treating mental illness, you realize our current toolbox, which is really symptomatic based medicine, just medicines to treat symptoms, they're not very effective, you know, and so patients just aren't getting better. So some people say it's this dirty little secret that's not, shared with our patients, but the medicines don't work as well as we thought. Psychotherapy doesn't work as well as we thought. So, to improve outcomes in mental health, we really have no path other than looking at nutrition and functional medicine.
Yeah, wow, that's powerful. I think you should scream it from the rooftops because conventional medicine needs to hear it, and so does modern medicine and functional medicine today. I'm so happy that you have your own group of students that you are training, and you're coming on board with us today to talk to our practitioners about this kind of stuff. I know I am pretty familiar with your background, but as went through in your education, I'm sure there's, various sources and what you were grabbing as far as the type and perspective you are practicing functional medicine. So I'm wondering, like, how were you introduced to our cryptopyral analysis and initially, and then now, how are you using it in your practice?
Sure. I mean, early on from college to medical school, I was just, fortunate and just attended every conference that was available. So they were, orthomolecular psychiatry conferences with Dr. Hoffer and Carl Pfeiffer. And then I went to environmental medicine conferences and Jeff Bland and the functional medicine group. In the old days, there were just 50 people in a room. And so I ended up in all these different arenas, the anti-aging, A4M, they all offered something. And then IFM. But nobody really addressed psychiatry and treating mentally ill. Now, the orthomolecular group started that way, orthomolecular psychiatry, but then they started getting into cancer and other things. So mental health just got pushed aside. So it
Mhm.
really became a mission of mine to consolidate all this incredible information that we had, whether it was understanding cryptopyrrole or understanding gluten or any other nutrient and how it affects mental health, and kind of organizing it in a way that one would help patients and two as a path to train clinicians.
Yeah, and that massive, consolidation that you've had to do, given what you've run into and studied and been around the leaders in the field is just not an easy thing to do. So, we're happy that you're doing it and for us, and you're here to teach because I think it gets murky. The waters get murky because as you said, you're in these rooms full of, leaders and advancers of our field, and um, it's tough not to get lost in that because we're constantly learning. Every year, we're discovering new things, whether it's surrounding neurotransmitters and brain chemistry or mold illness and toxicity. You know, we're just like never ending learning. So you're doing great. And I know that today our focus is really on the depressed population and the condition of depression. And I want to start off by asking you, how are you looking at depression in a way that's different than our standard primary care physician would be looking at that?
Sure. I mean, that's a 2-hour answer, but let's try to
Yeah, but you can do it in
simplify it.
2 minutes, right?
The well, let's start with the traditional model, right?
Sure. Yeah.
The
Perfect.
numbers are staggering. Depression is the greatest, highest number of disability worldwide, globally. So there are more
Wow.
people on disability for depression than cancer, heart disease, kidney disease. And this is not just the US, it's globally. We're talking hundreds of millions of individuals suffering. And then we have this treatment model. Let's take the United States. This treatment model, which is symptomatic, right? You have a checklist. If you're sad, if you're not sleeping, if you're feeling hopeless, we call you depression. We call you that you have a name, diagnosis. There's no concept of etiology, what's causing it. We give you a pill, and we have lots of different pills. And these pills are barely better than placebo. I mean, that is the tragedy. They barely work better than a handful of M&Ms. Now, that's the research. So maybe 50 to 60% get better. And then after a couple trials, we have this class of patients that the buzzword in my field is called treatment resistant depression. Okay.
Mm,
And that's almost 35% of patients. And think of the name treatment resistant depression. We're kind of blaming you. You're treatment resistant rather than kind of looking at the field. And it's that group where people are looking at psychedelics and ECT and TMS and all these other things that are partially effective. But what is not happening is nobody's looking at the underlying cause. And that's where functional medicine comes in. And that's been
hmm
my career. Some of it you would think is common sense. Like maybe you should check to see if someone is deficient in iron, they're anemic, or they have low thyroid. But typically, a psychiatrist doesn't do a medical workup. So I have my one line for my anatomy for psychiatry is just we have a neck, that what happens in the body affects the brain, what happens in the brain affects the body. And that's kind of the core of where we start when we teach functional psychiatry for depression
hmm
is a medical biological evaluation looking at factors that might be contributing to somebody's depressed mood.
hmm So you're a functional psychiatrist and you're dealing with higher level depressive conditions and people types from my understanding. When somebody comes to you and says they're depressed, is there anything that you are seeing on a health history or symptoms that they're describing for you that you know you are going to be running extensive testing for these individuals? Or the reason I'm asking is because I think that foundationally, there's so many things that can really help depression, but for you, you're dealing with really severe depression, psychiatric conditions. So I'm wondering what's the difference, and then in that difference, that's causing you to run testing. So I'm asking this because I know a lot of my practitioners are experiencing anxiety and depression in their client caseloads, but I'm wondering, like, can you tell them how they will know whether to like when to run extensive in-depth testing for these populations?
My model that's been almost 25 years is the testing has to be part of the evaluation. So that's we have to test everyone. We do a comprehensive
Mhm.
evaluation. Family history is often minimized, but that's critical. So
Yeah.
family history, current symptoms, But I don't think we should prescribe a medicine, nor do I think we should prescribe a supplement without understanding what we're doing. So to me, every patient that walks in the office, whether it's a primary care office or a psychiatrist's office, should have testing. And that testing could be basics like nutritional, hormones, cryptopyrrole, amino acids. I mean, the list could be long, but MTHFR, many kind of basic contributing objective tests that will help us plan a treatment path for that individual.
Mhm. How are you prioritizing between those testing? I'm thinking about the practitioners who are gonna be watching this, and when you say MTHFR, that's a key word. People have a lot of interest in that. When you say, nutrient status or a nutritional testing or the cryptopyrrole, how are you prioritizing choosing? So if you're running all of those tests, that's great, but which ones are you, like, bare bones foundationally starting with, and how do you know when to use which ones for your patient at hand? That's a very
Well,
loaded question. I'm sorry you don't have
no, no,
2
but
hours to answer that one.
no, but since the I think the punchline for me is you don't know.
Yeah.
So if you pick and choose, you might miss it. And that's why our evaluation for depression has to be comprehensive. I mean, depression is debilitating and obviously is life threatening. Suicide rates just continue to go up as we have more treatments, more medicines, more therapy, more hotlines. So, yes, there are some big ones like vitamin B12 and
Mhm.
vitamin D and thyroid and amino acids and cryptopyrrole, we'll talk about, and MTHFR. I mean, those we have to do. But I do an organic acid on everybody with depression as well. So it's hard to prioritize, but I think vitamin D, MTHFR, and B12 would be the three most important because they're simple, they're inexpensive, and they're completely um, ignored by most traditional psychiatry workups.
Mhm. Before we get into looking at a case study for you, um, what else do you want to I have a very, packed in question about, you detailing typical symptoms of your patients that are coming to you suffering from depression and how those correlate with specific chemistries that you're looking at, like some of the ones that you just named. So we can go there right now, but I'm wondering if there's anything else you want to say before we start diving into what are we looking at? How does it follow a map, look on a piece of paper, and then applying it in a real time, real case?
Yeah, I mean, we got thousands of cases. We can talk about that, but just to confuse the picture a little further, there's no such thing as symptoms of B12 deficiency because we can have a low B12 and we can find someone who's just sad and depressed and can't get out of bed. We can have low B12 and someone having panic attacks. We can have a low B12 and someone being agitated, someone having tremors, someone being psychotic. So this concept, which is one of the core concepts of functional medicine and the roots of cryptopyrrole and all the work of Pfeiffer and Walsh, is this concept of biochemical individuality. Everybody's
Mhm.
different.
Yeah.
So vitamin D is low, but it might mean severe depression for one person, and it might be mood is fine, but very significant immune abnormalities in the other. So it's hard to correlate these tests with symptoms. But we know all these nutrients affect brain function, and we know depression is genetic. So it's that
Mhm.
kind of combination of these deficiencies with someone's genetic vulnerability that creates this kind of symptom list, and it varies from patient to patient.
That was a great answer.
Thank you.
Can you go into a little detail about the specific nutrients that you're looking at again and again and again, making that are foundational to brain chemistry?
Sure. I mean, the list is long. We can think of
Mhm.
the macronutrients. protein, carbs, and fat. We have essential protein, essential amino acids. So that's critically important. A lot of depressed patients are eating adequate protein. So you think they have adequate amino acids, but when you do
Mhm.
testing, they don't because they're not properly digesting. They don't have enough acid in their stomach. So we want to evaluate the amino acid precursors to all the neurotransmitters. The essential fatty acids, the omega 3s and the essential 6s, are critical. We all have different needs. Some individuals have a piece of fish a week and their levels are fine. Others are very, very low.
Mhm.
And then for the micronutrients, we can separate them with vitamins and minerals. The most important vitamins are probably vitamin D, the B complex. We can do all of them from thiamine to B12 to folate to B3 and vitamin C. So those are big vitamins. And the minerals, every mineral is critical, but the ones we want to really understand when we're thinking about depression would be zinc, copper, magnesium, and lithium.
Mhm. Yeah, I think those nutrients are of really great interest, to a lot of practitioners in the field, and those just now starting to work with mental and emotional conditions in their practices and working with people with anxiety and depression. So I really want to continue to talk about that and focus on that during the case study. And I had a question, and now I'm forgetting. Um, what else do you think that we should talk a little bit more in depth on before I just let you really highlight a case study and how you've treated somebody with depression?
Well, I think I'll keep going back to this concept of biochemical individuality and just for all the nutrients that I mentioned, there are going to be cases where we just find one thing. We have a B12 deficiency, we replete with injections, and their mood improves. There are other patients that might have three or four different nutritional deficiencies or metabolic abnormalities. And there's some patients that might have more. And so that's why an individual approach is really important. And I mentioned genetics early on, but I just want to come back to that.
Mhm,
Depression runs in families. A lot of people don't get treated. A lot of people don't mention it to their family members, but getting a three-generation family history about depression or mood disorders is really helpful because if you have two or three generations of depression or hospitalizations or suicide, that's going to steer me in a different direction than someone that's had a stressful event in their lives and became depressed. So we really need to understand the history as well as the genetics to prescribe the best treatment plan.
how would that change the direction that you go in with that, one patient that you just highlighted
Oh, it
versus the
might.
one who had a tragic event?
Well, everyone who feels that there's been a stress or trauma, and then they get depressed and diagnosed depression, people say, "Well, it's because of this loss. I just lost my dad, and I should be depressed." And there's a difference between grief and sadness and what we're talking about, which is depression. And even though there was an event, traumatic event, a sad event, your chemistry changes, but then it reverts to a point where you're still can be sad, but you're not depressed. And 6 months, 12 months later, if you still function with depression, even though there was a cause, there might be biological things we can look at. And so people too often say, oh, because I had a stress in my life, I don't need medicine or I don't have nutritional deficiencies. But we still have to dig deep and look at these objective markers.
Mhm. Yeah, I think that's really good advice, and that makes a lot of sense. All right, I'm ready to hear about a case study from you. I have pretty much asked you everything I wanted to, so I'm just going to let you take it away.
Okay, I mean, I think I want to share two cases.
Perfect.
because one is on, well, both individuals were on antidepressants, and one was not doing well after multiple trials, and one couldn't get off the medications. And I think this is really important since with 40 million people taking these antidepressants and coming off these medicines can be really challenging, and oftentimes
Mhm.
the withdrawal symptoms are debilitating. So this is a great one for you and THA, because this gentleman has spent many years, 5 or 6 years, trying to get off antidepressants. He actually traveled the country to clinics. He went out of the country to clinics. He did every integrative, functional,
Wow.
traditional approach. He couldn't withdraw from these medications, from these antidepressants. And um, this is one of the simpler cases and pretty dramatic, but we did our testing workup, pretty healthy in many areas, but he had a remarkably elevated cryptopyrrole.
Mm.
It was in the low 50s as a
Wow.
cryptopyrrole level. And then he also had other markers of what I would call a functional B6 deficiency on the organic acid and on the amino acid test. So this gentleman who spent thousands of dollars trying to get help across many countries just had this genetic need for higher amounts of vitamin B6. Not sure the details, but as we started increasing the levels of B6, he started feeling better and could begin a taper off his medications. I mean, when you think about such a simple solution, and why is B6 so important? Well, you need B6 to make the neurotransmitter serotonin. Some people can't get off these medications, these SSRIs like Prozac, because it creates a deficiency of serotonin, and the body's just screaming when you stop it, "Where's my serotonin?" And without adequate B6, he just couldn't make it on his own.
Mhm.
So we've done a lot of work with antidepressant withdrawal. It's not always this simple, but we usually can find an underlying cause to support somebody getting off these medications. And there's usually a roadblock in the synthesis of serotonin. For this gentleman, it was really simple. It was just B6 deficiency that was picked up on a cryptopyrrole and an amino acid test.
Yeah, that sounds pretty simple. Dr. G, I'm wondering about this case study. So you saw the B6 deficiency and you saw elevated cryptopyrroles, and B6 is super important for serotonin production. And so that was a supplement that you helped arm him with to help him feel better, do better. I'm wondering what other testing you ran and if anything else was out of balance, or if perhaps a lot came back looking pretty good and the cryptopyrrole was the only part that was kind of a standout marker for you to focus in on.
Yes, you stole my punchline. That was why it's such a unique case, because I did all my routine testing, right? I did the amino acid, I did a fatty
Wow.
acid, I did hormones, I did organic acids, I did everything. Again, most of the cases I'm seeing now are consultations of people who failed treatment. So
Mhm.
I'm requiring them to do all these tests. And we found very little except for two dramatic things. The amino
Wow.
acids were all elevated. So, amino acids being elevated is often a B6 deficiency because B6 is required to metabolize the amino acids. And then the elevated cryptopyrrole is a reflection of a functional B6 and zinc deficiency.
Mhm.
So, that was so unique about this case of a gentleman who struggled for so long. And the intervention wasn't just 25 milligrams of B6, it was much, much higher dosage of a nutrient that he had never taken before.
Wow. That's amazing. Were you did this patient start to feel improvements immediately, or did it take some time with the supplementation?
This particular patient, again, because it was so dramatic and he's felt so bad for so long, really felt the difference in weeks. I mean,
Wow.
not completely off the medicines yet, but the withdrawal phase that he's been in for a protracted period of time was
Mhm,
relieved as the B6 started being titrated up.
mhm. Did you put him on a supplement protocol for the elevated pyrroles? Of course you did, because you had a B6, but I'm wondering if you retested the pyrroles in 30 days, 90 days to see what, they looked like then.
Now we haven't retested yet. He's right. He's
Oh,
got
this is a current case.
yeah.
How
This is
fun.
someone who's just and that's why it's so dramatic. And usually it's not
Mhm.
that simple, but it's so gratifying
Yeah.
to see.
So, is that the plan? Will you retest pyrroles again? Or is it, you saw the cryptopyrrole one time and you saw what you needed to see kind of thing?
No. Cryptopyro is one of the tests that I would often repeat, whether it's
Mm,
2 months or 3 months, because I mean, we're obviously everything is based on clinical improvement, how someone's doing, but it does vary and it increases under stress. So I want to make sure that it's completely normalized and what dose of B6 and zinc
mhm.
that was required.
Yeah, so does the cryptopyrrole test show anything other than this genetic abnormality that could create a zinc deficiency and a B6 deficiency?
There are some other micronutrient variations that support it, but for me, I just focus on repleting with B6 and zinc
Okay,
from
cool.
an elevated cryptopyrrole.
Excellent. All right, thanks for answering all those questions. I want to hear about your next case study, so you can take it away.
Sure. Again, this was a woman that I saw when she was in her 40s. She has a history of depression in her 20s. Took medicine, was fine and completely fine for many years. And she was a unique patient because she did everything she was supposed to do, right? She flew in her organic salmon from Alaska and she only ate health foods. She did her yoga class and her breathing and her mindfulness. And she was the perfect, you know, health person. But she developed this depression, not function at work, not able to run her business. She went to her primary care doctor, and they just did, a one blood test and said everything was normal. And they just started this game of putting people on medications.
Mhm,
So she started one medicine, didn't work, so they added the second medicine, which is common. And then that didn't help. So they added a third medicine. And when that doesn't help, they send you to the psychiatrist or the psych provider. And they, rather than stopping a medicine, they add what's called a mood stabilizer. So this
mhm.
woman came to see me on four medications and a benzodiazepine to, to help her sleep. So five
Yeah, Dr. G,
total medicines.
sorry to cut you off. Can you share what medication she was put on in what succession, if you remember?
Yeah, certainly. So they start with an SSRI. So this
Yeah.
particular one was started on Zoloft, and then they add a medicine called Wellbutrin because it works a little differently, and then they add what's called a mood stabilizer, and then they added Lamictal, and then she got the Ativan, the
Mhm.
benzodiazepine. So when she came to see me, her words is, I feel worse. And
Yeah.
we did all the same testing. Again, when I see patients as a consultant, I require all the testing. So we did a cryptopyrrole and amino acids and fatty acids and B12 and hormones and hair tests. Everything was normal except for one test. It was the fasting amino acids. Okay, so everything was very low. So her essential amino acids were deficient. And amino acids are the precursors to all the proteins in the body. But
Mhm.
As a psychiatrist, for me, it's all the neurotransmitters in the brain. So she didn't have the building blocks of serotonin, of dopamine. And oftentimes I see this in adolescents because they're eating junk food or pasta and they're not eating protein. But again, this is a woman who ate her salmon from Alaska and her grass fed beef. So she was eating adequate protein. But what happened is she was getting under stress. Her digestive system just kind of shut off. So she didn't have the hydrochloric acid and the digestive enzymes to break down the protein she was eating. So when we have
Wow.
low levels of amino acids on a test, you don't feel well. I can look at that test, just like we got a high cryptopyrrole, and we can say, I don't know exactly if you're anxious, depressed, irritable, but you can't really feel well with a cryptopyrrole of 42. And I can tell you with low essential amino acids, you can't feel well. Most people would feel fatigue, depression, lack of motivation. So all we did for this woman is to give her scoops of free-form amino acids, right? So she was
Mhm.
getting the building blocks. And then we gave her the digestive enzymes. We gave her hydrochloric acid and the digestive enzymes to help her break down this incredible organic food she was spending all this money on. And, the free-form amino acids work quickly. So a couple of weeks, she started feeling better. In a couple months, we began this taper off of these medications. And this is someone I've known for years, and she's been off all these medicines for a number of years and doing quite well. So it's not a typical test psychiatrists look at, fasting level of amino acids, but it's been essential for my practice in treating depression.
Mhm. Wow. So again, I asked this question for your last case study. How soon was she feeling the effects of your plan for her?
I think for this one, it was about but within 2 to 4 weeks of taking the amino acids, you're going to feel better because it's not like eating a protein powder or protein drink. You don't have to digest it. So these are just the essential amino acids in a powder, so they're easily absorbed. So people usually feel better in a couple weeks, and these are taken before meals, at least twice a day.
Mhm. And then, so you're a psychiatrist and you are used to be dealing with these types of patients in your practice. For the unlicensed practitioner who is watching this right now and learning from you, how are they able to support a patient like this when this patient is on medications? This patient probably has a primary care physician or a psychiatrist who has prescribed these medications. Are they still able to run this testing and make the recommendations you're making without, um, of course, not managing their medications in any way? But how can you give them recommendations for how to help?
Yeah, I'm not sure about, scope of practice for different
Sure.
disciplines and health coaches. So to me, the most powerful intervention is education,
Mhm.
um, providing the information to, our patients. Also, I do think there are many, programs like yours where patients can at least order some of the tests and then get access to kind of trained professionals to help interpret
Mhm.
these tests. But I think just awareness is such an important part of this struggle because that provides hope. I mean, so many of our patients with depression are just tired of taking different pills, tired of, being in therapy, even though it feels good and supportive, it's not going to necessarily treat a depressed mood for some of those individuals. So to have access to a biological model just kind of gives hope to so many patients.
I think that's such a good key point to bring up is the hope part, it doesn't matter if you're a licensed psychiatrist or unlicensed functional medicine practitioner or a nutritionist or, an RN or something. It's, connecting with that client or patient with their pain points and how they've been suffering in this certain way can do a lot as far as giving them hope and providing education so that they can go back and bring that education to who is overseeing and treating them. Because, of course, a lot of professionals in our industry, like it is, as you said, scope of practice is important. So I appreciate your perspective on that because it's really driving education and building relationships with these people to help them do better, feel better in a way that makes sense for them and is within their scope of practice.
Yeah, and
So let
when we think
me
of, can I just follow up on what you said
Yeah.
again? When I mentioned the term treatment-resistant depression, we're essentially blaming the patient, and that's how many individuals feel. So they feel shame and guilt because they're depressed and they're disappointing their loved ones. They know they're supposed to go to the gym and they know they're supposed to do this, but the depression gets in the way. So by providing that hope and taking away the shame and guilt that it's not their fault is
Mhm.
probably the key in that therapeutic relationship.
Mhm. Do you have any advice for, let's say, somebody who just finished a functional medicine school of thought and is just starting to work with mental and emotional conditions? Do you have any recommendations for someone who really wants to work with these populations but is just starting out?
Yeah, so a little biased because we created our program to focus on those with mental illness, and I think getting a broad perspective on functional medicine is foundational. But if you're treating someone with depression, anxiety, or ADHD, my advice is to try to get the information from someone experienced and who's treated it, because too often in our field we give these blanket, you know, just do food allergy testing or just do this testing. And I think our patients with mental illness have really not gotten the treatment they always deserve because it just is a specialty. And I think the education should be obtained by people familiar with the illness.
I'm so happy you joined us today, Dr. Greenblatt. I want to finish by talking a little bit more about our cryptopyrrole analysis. You mentioned it for your first case study, and that was something that was the thing that was creating this guy's, decades long deal and bout of depression. I'm wondering, um, we are recommending the cryptopyrrole analysis for many conditions. So it's not just depression and anxiety, it is any real mental and emotional condition and conditions outside of that scope of things too, because of its relationship with the building blocks of neurotransmitters. So I'm wondering, from your perspective, why do you think and believe that the pyrrole test is essential for people regarding any condition they're suffering from?
I mean, there are many reasons, but it's one of the essential tests that I recommend for every patient who kind of walks in our offices, and in our training programs, it's an essential test that we recommend for every clinician because B6 is just critical again for the synthesis of the neurotransmitters and the breakdown of protein and so many other products. So B6 deficiency affects every mental health condition. So I'm not a big fan of the checklist. Do you have cryptopyrrole? If you have these four symptoms, do a test, because there's not four symptoms, there's 4 million symptoms. So any psychiatric patient should have a cryptopyrrole. B6 deficiency affects you and me differently,
Mhm,
but it has profound effect on mental health. And zinc as well. Zinc is critically important to hundreds of enzymes in the brain, neurotransmitter synthesis, and also people forget for the entire digestive system, from taste to acid to all the enzymes require zinc. So we get this complex gut brain interaction. So these are just two core nutrients, and don't take offense, but for inexpensive urine test to get so much information, it's just really a no-brainer for a mental health
mhm.
practice. Um,
Definitely.
and
Yeah.
um, and that's why it's kind of a standard recommendation. And again, we've seen it from psychosis to anxiety to paranoid to depression to any other symptom. And sometimes it's the answer, like the case I described with you. Sometimes it's just part of the puzzle. But once we understand the pieces of the puzzle, we can develop a treatment path to support recovery. And our traditional models are only 50-50 at supporting recovery.
Mhm. Wow. 50-50 is not great.
It's embarrassing, and it really is, for our traditional model. And some people might argue 60%, and we'll give them that. And I think in the hands of a good psychiatrist, yes, medicines are going to help some people, but
Oh, sure, and
not.
I say it all the time. I say all the time, I say, "I'm not demonizing, modern medicine, and I believe there's a time and a place for medicine." But
And I
I
haven't
think
thrown
we
away my prescription
over-medicalize.
pad,
Yeah.
and
Yeah.
absolutely, and teach people how to prescribe medicine, but there's just such a huge gap in terms of
Mhm.
nutritional psychiatry and functional psychiatry.
Yeah. Awesome. Well, thanks, Dr. G, for your kind words and for giving us your take on all of that. Now I'm going to turn it over to live Q&A. So let's get going with that.
Great, thank you.
You're welcome. Excellent. Dr. G, thank you so much for being here with us today. We just listened to your webinar. I saw you check in a little bit ago, and we have so many good questions for you, and we're so happy we're here. So everyone, let's welcome Dr. G in the chat, and I'm just going to jump into live Q&A.
Great, let me know.
I'm going to start with Maureen's question. Is it possible for someone to come off antidepressants after 40 years?
Yes, I would say slowly, but absolutely. We have a new book on antidepressant withdrawal. The first step, the foundational step, is doing all the functional medicine testing before you begin a taper. And that's the biggest challenge people have had. They start the taper while they start repleting nutrients. It should be done before. But yes, absolutely. Some people could come off with 40 years in a simple 3 months. Other people, it might take years. But yes.
Yeah, I love that. Can you speak a little bit about P5P versus B6 for depression? This is a question from Allison that was submitted before.
Yeah, I think I found a number of years ago, this has to be about 15 years ago, that I started seeing better results with B6 than P5P for some of my cryptopyrrole patients. And then I spoke to Kelly Heim at Pure Encapsulations, who's a pharmacologist. He's a brilliant PhD. And I asked him to help me understand. I thought P5P was activated and the better source. And he explained to me that if you take P5P in the intestine, your body breaks it down and takes off the phosphorus, and so it's just pyridoxine, and then you add the phosphorus back. So I think there's a lot of hype with P5P. I always use either B6 and P5P as a combination, or just B6. Again, I think over my career, I've just seen a lot of fads with supplements because, vitamin C, magnesium, and B complex are boring. So we have to make things exciting. And I think P5P got caught up in that. And the reality is B6 pyridoxine works as well for many people, in my opinion.
You mentioned pure encapsulations. We have a question from someone here live today. Are pure encapsulations amino acid capsules as effective as the powder? Do you have any experience with that?
Yeah. No, I all the amino acid formulas I've used for many years with Pure. The the powder is the best. Pure has one called Amino Replete, and there are other companies. The powder is just better absorbed. To get the amount you would need in a uh, scooper of the powder, you're probably talking 8 to 10 capsules. So it's hard to get free-form amino acids, sufficient quantity, I'm sorry, in the capsules. What we do use the capsules for, the more targeted amino acid precursors like tryptophan, 5-HTP, phenylalanine, and tyrosine. But for the free-form amino acids, I would stick with a powder.
We have a ton of questions about B6. Here's one from somebody live today. Do you have any recommendations for helping patients tolerate high dose of B6 when they are experiencing nausea? She is using Pyrrole AM caps from Brain Science Nutrition per the Walsh protocol, and she is seeing lots of elevated pyrroles in her practice.
Well, I just would be cautious with combination products. Um, so, I think things have changed over the past 5 years, whether it's, COVID or our diets or whatever else. But I think we're just seeing so many hypersensitive patients who can't tolerate many supplements. Um, so I would strongly urge this clinician to just use a B6 supplement separately, titrate that up, and then use a zinc supplement separately and titrate that up. The combination pills are sometimes they work, but in my experience, 50% of the time they're problems. Then you don't know what nutrient in that combination pill is the problem. And I would caution the word high dose B6. You only want the amount of B6 to bring down cryptopyrrole. For some individuals, I've seen it go down with 50 milligrams. I've also seen people need 400 milligrams of B6. So that's why I just like titrating B6 by itself so I can know the lowest, safest dose to bring down cryptopyrrole if that's our target.
Hmm. Yeah, that was a great answer. I think titration is the name of the game there since we're having these reactions to or we're seeing the reactions to these sorts of supplements. Somebody asked a question, can B6 be too high, counteractive? And same goes for zinc. So if let's say you have pyrrole disorder, your B6 and zinc is at a deficiency. I think they're asking if we are titrating that up. Is there, I mean, too far, they might have other negative symptoms, but could that counteract?
Yeah, absolutely. I mean, we get a little cavalier and carried away with supplements because you can buy them, at the drugstore. But they have profound effects, particularly an isolated B vitamin affecting all the other B vitamins. And certainly there are potential side effects, including neuropathy over 100 milligrams. So I just caution everybody using a just going for a dose of B12. The titration is critical. And again, it varies. I've seen cryptopyrroles disappear. Someone just took 50 milligrams a day of B6. About also, again, as I shared, 400. So please titrate up slowly.
Hmm. Yeah. And then how will they know? Shauna asked, how will they know when they reach the ideal dose with B6 and
And that's
zinc?
why cryptopyrrole is a test that should be repeated. You don't
Mhm.
know. There's no ideal dose. Um, the nausea, um, the B vitamins could be taken with food. Zinc is more commonly associated with nausea. And that's why you might need a lower dose of zinc. Again, titrating each micronutrient separately is going to be much more effective and minimize all side effects.
Excellent. Thanks, Dr. G. I'm going to switch gears here a little bit and ask, do you do any genetic testing for your patients, especially for those with long family history? This was a question from Rebecca.
I do genetic testing on every patient that walks in the office. I try to do a 3-generation family history because there are lots of symptoms that don't get diagnosed. Uncle Charlie, and that was in prison. Nobody talked about. Susie was this, that, and the other. So 3 generations family history, and I look at genetic testing on every patient. Certainly MTHFR, I think You cannot treat a treatment refractory depressed patient without having an MTHFR variant. And then there are other genes that just make it much easier to develop a treatment plan.
Great. Thanks, Dr. G. I have a question. So Shaman just asked a really great question, and I know you recently talked about this on your podcast with Dr. Mark Hyman. She says, in co-occurring MDD and SUD, I'm in clinic and find a lot of resistance to using the KPU or even talking about the use because it's not evidence-based in the minds of mainstream. What do you have to say for that?
Well, let's agree with you. It's a great question because, out of the hundreds of hours of content in our training program, I do think cryptopyrrole is the least researched, but the most powerful clinical effect and experience. So I'm actually talking with your colleagues at DHA about a research protocol um, for cryptopyrrole because I think it will be simple and very powerful. But it's an important question. And I think a urine test that's so inexpensive, we can work around it. And you have doctors, around the globe who've been looking at this clinically. If you really can't get any buy-in with colleagues, um, you can just empirically treat with a B complex and a micronutrient trace mineral supplement. So there are times patients can't afford any testing, and we have a suspicion that I might use higher than normal B complex doses and zinc as a supplement.
Mhm.
But I think the cryptopyrrole test is so dramatic because you just see a number and you have an intervention and you watch the number go down and you see symptoms improve. So for any skeptics, it just takes 5 patients to really see something dramatic. And so if she can try to convince her colleagues, can we just try this for 5 or 10 patients? It would be incredibly helpful.
Yeah, that's a great answer. Thanks, Dr. G. And speaking of that, you guys, when you run our cryptopyrrole analysis on your clients through us, you are offered a free complimentary consultation through our consultation program. So it's a really great way to learn more about how to analyze the results of the KP and get some guidance if you're not that familiar with it, or if you have a really tough case and you just want to talk to one of our physicians. Unfortunately, Dr. G is not one of those physicians, but we have a couple of very qualified physicians who do talk to our to our practitioners. So I wanted to mention that. Here is another good one. What are some of the most common nutrient deficiencies that practitioners should keep in mind for their patients who are using SSRIs, SNRIs, and or TCAs? From Jamie.
Well, the list is endless when we think of the cofactors um, that are required for the synthesis of these neurotransmitters. The list is long. The big ones I've mentioned in the presentation. So vitamin D is the cofactor for the rate limiting step in serotonin synthesis. B12, folate, magnesium, zinc, and microdoses lithium. I mean, those are the big ones that all need to be repleted before anyone would um, need to either withdraw from medicine and or there was a expression in the old days called Prozac poop out because people did better for a few months on the medicine and then the effects kind of disappeared or plateaued. And we often see that with individuals who have these same nutrient deficiencies. So the big ones would be vitamin D, B12, folate, B6, magnesium, zinc, and lithium.
That's a great answer. So, when do you recommend 5 milligrams lithium orotate supplements? 'Cause I know you practice that, I believe.
Yeah. No, lithium has been part of my practice for 30 years. Certainly for kids, I usually start off with the 1 milligram. So use 1 to 2 milligrams to start. And we use it all the time. Um, I use it particularly with family histories of addiction. It's probably the most powerful. intervention, even though the patient in front of you might not have an addiction, but family histories of addiction and the symptoms that it's most commonly used for is irritability. So kind of mood lability and irritability.
Thanks, Dr. G. What might cause a child with ADHD to have low B6 as seen on an OAT test? So the OAT is the organic acid test, it's a urine test. I can tell you right now that ADHD is pyrrole disorder is very common in ADHD, but I want to hear from Dr. G if you have anything to add to that.
Yeah, I mean, the organic acid B6 is not the end all marker. So that's just looking at a urine excretion. It's something that I'd keep in the back of my head, but you wouldn't aggressively treat from an organic acid. But what you'll find, as Caitlin brought up, is you'll find those that have very low or undetectable B6 on the organic acid might have elevated cryptopyrrole, might have elevated amino acids. So there are other functional markers of B6. So the organic acid is not the best test to just utilize B6, but if you do it in addition to the cryptopyrrole amino acids, then you'll kind of correlate that.
Thanks, Dr. G. Is OCD usually associated with any specific abnormalities? Yes, it's associated with pyrrole disorder. What else, Dr. G? Do you want to add?
Well, I mean, the question is so important that I have a 6-week training on it because it is,
Perfect.
and the reason I haven't done this before is because OCD can be addressed through functional medicine testing, but it's not simple. And all the tests we've talked about today could be related. Cryptopyrrole, absolutely. But we see gut problems and digestion problems and micronutrient problems, and the list is very long. And it's always been challenging for me to talk about OCD in a 1-hour lecture, and I just haven't done it. I wouldn't do it because we would miss all the other things we can't talk about, and people would get disappointed. So at Psychiatry Defined, we did set up a fall training on OCD where we will go through all the factors, and there are just many, and that's what makes it complicated, but also very treatable with a functional medicine approach. Yeah, there's actually a free webinar coming up on OCD and
Cool.
inositol treatment. So that's is a free webinar.
Perfect. Is there a common MTHFR result you see with anxiety and depression?
Well, I mean, there are 3 variants. We talk about, any T for the MTHFR is trouble. So 2 T's has a very significant impact on methylation and is very high risk for every psychiatric disorder. So we have literature, there is research on MTHFR variants higher in everything from schizophrenia to addiction to depression. In my clinical experience, we've seen it with anxiety, OCD, not as much literature. So that's why it's so critical that it's tested on everyone. And if there is an MTHFR variant, then I'm not a huge fan of high doses of folate. I start with low doses of folate, but L-methylfolate can be just an incredible adjunct to treatment with MTHFR variants.
Thanks, Dr. G. Is pyrrole elevation commonly seen in autism?
Absolutely. That's where we first started seeing it.
Excellent. Gonna switch gears here. I know you're the amino acid guy. Can you speak to the importance of having tryptophan within the performed amino acids? Thanks.
Yeah, when tryptophan was kind of taken off the market because of contaminants years ago, they started putting together amino acid formulas that had all the essential amino acids, but not tryptophan. And that is a recipe for a depression or side effect. So you just want to make sure if you're taking an amino acid powder that it has all the essential amino acids, including tryptophan. There are some on the market that don't have tryptophan, and I guarantee if you take that for 2 months, you'll feel irritable, depressed, or anxious.
Thanks, Dr. G. Karen is asking, how does psychoneuroimmunology help to treat treatment-resistant depression? What do you know about that?
Well, that was the name of a course that we put together 40 years ago, when the term first came out. So, I just think that the concept is how the immune system, affects the brain and how the interaction, affects the body. And the short answer is it involves every aspect of mental health and mental illness. So we know that inflammation from an infection can trigger depression, and we know depression and grief can trigger inflammation due to the stress response. So it's just intimately tied towards every kind of mental health symptom or major mental illness.
Do you have any advice for practitioners who are struggling to help their clients afford testing?
No tips. I think as many medical diagnoses and nutrition and malnutrition, and nutritional deficiencies diagnosis, it's easily better covered. But some of the functional medicine tests aren't covered, and that's a challenge of any functional doc. It's a huge ethical, cultural question that is really a dilemma, particularly as functional medicine over the last 10 years has gone from a fringe group treating patients that could afford it to now, we have docs in the VA and community mental health clinics who want this information, want to understand, and the cost for some of these tests are a challenge. But there are tests that, are more reasonable, and some oftentimes we're talking about life saving or getting someone off a trajectory of a major mental illness. So it's important, but I have no great answers for this real challenge for all of us.
What I had to look up what this word meant, but so maybe you can explain it in your answer. But what could be the causes of derealization? And what would you choose as far as treatment options?
Um, well, it could be a little of everything. A lot of the last few people I've seen were smoking a lot of pot. So adolescents who had doing fine, smoking pot, and then had one bad experience and couldn't come out of it. So um, this concept of derealization, and it's kind of linked with depersonalization, these kind of out of body experiences, could be due to any of the micronutrients we discussed. Certainly, we always think of the psychological and trauma. So it's not uncommon that it's a trauma response. But even if it is, as I said earlier, we want to address and treat the trauma and be supportive as best we can. But that individual might also have a B12 deficiency, an elevated cryptopyrrole, or an MTHFR variant. So if we can optimize the biology by doing those testing, then the trauma treatment is just going to be much more effective.
Mm-hmm. Thanks, Dr. G. Do you have a preferred micronutrient test?
No. I mean, I think I use the hair test a lot for zinc, copper, magnesium, and lithium. You can't read everything off the hair test. And so I guess over the years, I've tried lots of tests and none have been consistent. So that's why I have to look at a lot of tests to put the puzzle together. So, it's cryptopyrrole, it's hair analysis, it's amino acids, fatty acids, and serum levels.
Awesome. Thanks, Dr. G. Karen is asking, where can trainings be found to interpret the lab that shows a marker for cryptopyrrole? So, Karen, I said this earlier if you didn't catch it. When you order through us, you can get a complimentary consultation through one of our consultants for every single order when you're ordering a KP. But I'm curious, Dr. G, do you have any training specific to the cryptopyrrole, or is it pretty much just woven through all of the stuff you're doing out over there in Psychiatry Redefined?
Yeah, no, it comes up in, lots of areas. Our fellowship, it's one of the core tests, and there is a separate module on cryptopyrrole.
Great. I have someone submitted this question ahead of time. What are your thoughts on ketamine therapy?
Um, well, neutral to caution. I've seen ketamine therapy be helpful, but I think at this point, um, we've kind of gone overboard. Ketamine clinics are open up of every corner. It is now seen as a financial benefit for the doctors and nurse practitioners who are doing it. It's being administered to people, as we know, um, Matthew Perry, the people that abuse ketamine. So I think it had potential, but I think it's not the panacea. And if you don't test a B12 level, it's pretty stupid to use, a psychedelic.
I love that. I love that very measured answer. I think that that's a hot button right now. So I really like to hear what you have to say about it. I only have one more question, and is the free-form essential amino acid powder safe for children?
Yes, it rarely, when I say children under 12, I usually don't see amino acid deficiencies. Um, but absolutely, if you see amino acid deficiencies, and I use it in adolescents all the time, it's a standard for anybody with a restrictive eating disorder, fatigue, chronic fatigue, things of that nature. For a child, it's absolutely safe if there's a need.
Thanks, Dr. G. And then we actually have one more I missed. Are there any nutrients depleted or connected to PMDD? This is from Elena.
Yeah, I
This
mean
is
the core premenstrual dysphoric disorder is we go back to B6 and magnesium. Um, it's really important. And the third one would be evening primrose oil. So it can take 3 months, but you'd want a B complex, then high dose B6. Magnesium is critical, and the essential fatty acids, GLA and evening primrose oil.
Mhm.
I bet you nickel, 90% improvement just on those.
Wow.
But if you do the testing, you'll be able to find other things, hormonal precursors to really treat, premenstrual dysphoric syndrome.
hmm Thanks, Dr. G. What amino acid level test do you prefer? This is a question from Christina Veselak, who you probably know.
Yes, hi.
Hi,
So
Christina.
I've just been the fasting plasma amino acid test is the one that I've used for probably 25 years. It was a test that never made sense to me when I first started using it. What if they had steak for dinner last night? What if they had just salad? Wouldn't that affect the amino acids? But doing hundreds, if not thousands of patients, I've had patients with anorexia have high levels and patients that are eating protein, as we discussed, eating low levels. So the fasting, it has to be fasting. Plasma amino acid is the test I use most often. Occasionally, I've seen urine tests that have been helpful as well, but plasma is the most helpful.
Awesome. Thanks, Dr. G. That is pretty much it for our questions. But first, can we all give Dr. G a round of applause? We're so happy, Dr. G, you came on with us. You answered more than 25 questions in 30 minutes, which is a world record. And we just so appreciate your time and being with us here tonight.